Let me invite to the stage Bill Akers, General Manager and Senior Vice President at Premera, Pam MacEwan, CEO of the Washington State Health Benefit Exchange, Caitlin Safford, Director of Government Affairs or Relations, I was never entirely sure, at Amerigroup, and Sean Graham, Director of Government Relations at the Medical Association. Let's give them a round of applause. Come on up. Thanks, guys. So you all will get an opportunity to ask questions as well. I mean, if you're sticking around here and with us to the end, I want to make sure you have an opportunity to do that. Caitlin, let me ask you first, though, to sort of start us off. You've been at a number of our state reforms. You've been to this state reform before. You've been here all day. What are your takeaways from this specific conference now that you've been drinking from the fire hose? And congratulations on your pregnancy.
Thank you. Yes, quite obvious sitting down here. I think it was just as content rich as normal. This is my favorite State of Reform conference that I get to go to. It's the most honest conference I think that we have. The conversation is always that. It's like a very intelligent conversation. And sometimes in Seattle you get more talked at, and here it's a lot more about talking with each other and trying to figure out solutions. I don't think today was any different. I think even I was at the Medicaid panel, of course, because we're a Medicaid managed care company, and even in the questions that were being asked were a lot of like, how can we fix this problem and what can we do as a partner to figure out how to discharge difficult to discharge patients, both medically and behaviorally complicated. So, that still continued, and it was enjoyable today, just as ever.
Pam, same kind of question. You've been very gracious in your engagement and support over the years. Thank you. How do you reflect on today? What are your takeaways from the conversations you've had either in the sessions or in the hallways?
I have similar feedback. What I like about Spokane is it's smaller and it tends to be much more interactive. And I think people are pretty courageous in the questions that they raise. So there was some really, interesting dialogue. Particularly, there was in the Cascade Care session, which I went to the questions, not the presentation, because I knew the presentation already. Yeah. But there was some really good dialogue about benchmark pricing and areas where Cascade Care has ventured out, and it was really good to kind of hear that feedback and discussion.
So characterize that broader conversation both today about benchmark pricing, but also within the broader context of the public option. What are you hearing? How are people sort of coming around to some of that vis-a-vis where they may have been in the legislative session? What are your thoughts?
I would agree with what you said this morning, which I think people have calmed down considerably from the ledge session where there was a lot of angst about where this might be going or what it might mean. And my sense is that people have really pitched in to work with us. We have 2 stakeholder groups going on the standard plans, and people have been really involved and working hard. And I've been hearing a lot about people wanting to start working with Healthcare Authority kind of on the next stage of this. So my sense is that there's skepticism in some camps and a lot of enthusiasm in others, and there's a real let's see what's going to happen and let's see if we can make this work.
Yeah, Sean, thanks for coming over and doing this. I appreciate it. The Medical Association is one of those organizations that had some concerns, but with the public option bill. But this is preface for my other contextual question here in a moment. You guys purposefully stayed at the table. You didn't throw stones. You guys tried to be as constructive as I think you could, recognizing your members had some concerns. Jennifer, your CEO, made a real effort to keep everybody together and constructive and not be difficult. You all as an organization seem to have kind of doubled down on public policy in terms of some of the organizational changes that you all have made recently. Is that accurate? And what does that mean for the future of physician advocacy? We're going to hear more from you all.
That's interesting. Yeah, a good question. And to the part about WSMA internally, and I'm sure this is very interesting to everyone to hear about, our internal restructuring. But I think it does have an interplay with the public option issue, among others. We've put more of an emphasis on having a policy team internally. The reality is, the sheer volume of bills and regulatory items and stuff that we're faced with as our other organizations, it was very difficult to stay on top of with a smaller shop. So we built out a policy arm as well to make sure that when we are engaging on this, we're doing so in an informed manner. And the public option was, I think, a good example of that. To your point, we made a concerted effort to be collaborative in the way that we engaged on that. From the outset, we noted that, we share a lot of the concerns that advocates had about the plans that were available for purchase on the exchange. We wanted to see consumers in better health plans. We were consistently opposed to rate setting, a rate cap as being a part of that public option, and we're opposed to the bill in its final form because of that. But I do think, we did, to your point, we tried to make a good faith effort to be collaborative and constructive in how we were engaging on the issue.
Yeah. One of the things that we try to do at SEER Reform is have this kind of multi-silo conversation. And so where you get different perspectives, different blind men and women around the elephant, as we say, to rely on the old allegory, so that each of the four of you have very different perspectives is kind of cool and fun. So Bill, you're not necessarily a policy guy, but you have to live in that regulated space. As Premera's leader of the group market, 500,000 people, how would you characterize trying to live in this space as an insurance executive compared to 3 or 4 years ago? Has it calmed down, I assume, or is it still kind of crazy?
No, I don't think it's calmed down at all.
Yeah.
I think it's ramped up, if anything. And I think it's similar to Sean's comments. There are the particular business objectives of Premera, and then there's the healthcare environment. And we have some overlap, but maybe not universal alignment about our opinions on both of those two things. So I think at the macro level, we believe that anything that's going to help advance the ball in, I would say, a fairly broken industry is worth spending some energy on, even though there are some tenets of a public option that would threaten private insurance, right, just on its face. So I think one of the things that the ACA has taught us, but other things too, working with the Healthcare Authority on a couple of different other projects, being in the MA space, even in the med sup space, but there are a number of different things that have happened, I would say, in the last 10 years that lead us to believe that there will be good ideas that come and good ideas that go. There will be some that stick and some that don't. And I don't think that it has to necessarily be a 100% failure or success. Mm-hmm. The ACA we've learned a lot in 5 years, and I would say that we are still at the very tip of learning. Pam and I were talking at the outset here a little bit. It has stabilized quite a bit, but I don't think anybody's sleeping that the next 5 years are going to just be this smooth, predictable situation. And there are a lot of influences in that, both locally and nationally. On the policy side and in the care delivery side and in the insurance space, all of those things are going to come into play. So, but at the end of the day, I think, DJ, for us is we have a business to run. We're trying to adapt and create some disruption in a broken market. And some of those things are going to be ideas that scare us a little bit. And that's okay. It's probably okay.
Maybe speak to that, the culture piece and sort of leading with confidence into uncertain times. And specifically, Premera's CEO, Jeff Rowe, came in following long-term tenure of Gubby Barlow and really has, I think, worked to put his consumer-centric cultural stamp on the organization. How would you characterize Premera's culture today versus 5 years ago when Jeff was first coming in?
Yeah, and I'd maybe back it up to make the analogy maybe a little more real. As Pam and I were talking, I've been with Premera a little over 15 years now. And previous to that, I had 12 years in the group health world. And when I came to Premera, they were coming off of maybe their second or third year in a row of making money. In the late 90s, they were on the watch list or close to it. Mm-hmm. And Gubby was an accountant by trade, an operations guy who came in and really led the company through a tough period of we're just going to get better next year than we were last year, a little bit at a time, created some real financial stability for the company, made some bet the farm kinds of decisions about our operating systems. And he brought in a lot of talent into the company. So we moved from a company that was kind of on the verge of maybe not being there anymore to a company that was more stable. By the time Jeff came in, we're starting ACA, and with all that turmoil that was going on in the market, it was kind of important to have a market-facing guy there, because Jeff's whole thing is, if you're not sure how it's all going to play out, then stick as close as you can to your customer, because that's probably not a bad place to be. Mm-hmm. And I think that has really helped us. So I kid that Jeff could never have he wouldn't have been the right guy for the job when Gubby got it. And likewise, Gubby wouldn't have been the right guy for the job when Jeff got it.
Yeah. Pam, how would you say the expectations of the exchange have been met in terms of activating consumers? There's so much of that talk back in 2009, 2010 when the ACA was getting developed, and the exchange has thought about a lot of different models, from active purchaser to other kinds of things, and it's stabilized and doing well now. But we haven't necessarily seen as much, it feels like we're always talking about activated consumers, and they're still less activated than we think, or at least that I think. How do you see that question, and is the exchange a tool for that or not, in your view?
Well, I think that, I sort of have two answers to that. One is the very positive. And when we first started the exchange, people had no clue about buying insurance. And there were, thousands of people in the state who hadn't had insurance. They didn't even really know what it was. And we see year over year people really understanding better what it is they're purchasing, the value of insurance, that people want insurance, and we've done a lot of health literacy at the exchange, kind of working with our navigators and brokers about kind of teaching people deductible, copayment, understanding what they're buying, the difference between a premium and deductible. And there's still, sometimes all of us up here don't like those terms either, let alone how they land on consumers. But we've seen just the health literacy just really grow. And we have, tools like consumer decision support tool that allow people to kind of put their doctors in and how much they, their pharmaceuticals and how much they expect to go to the doctor. So they start to kind of get what it is to purchase a plan. But having said that, I think the other side of it is that, paying and, purchasing insurance is not people's favorite thing to do. And it's a challenge to engage them in that and to get them, wanting to look around and spend time making their decisions. And we also, I think people are really much more interested in their health than they are interested in the financing mechanism. Mm-hmm. So we are really interested in kind of breaking out and working more in communities, understanding social determinants of health, or how benefit design can really promote health. But we have been caught in this race of trying to get premiums and deductibles under control. And I think in some ways that's distracted our attention from the mission of engaging consumers. Mm-hmm. And what we're hoping is that as we can get things to be more affordable, we can kind of get back to engaging consumers more.
Yeah. Sean, not about activating consumers, but in terms of activating physicians. 20 years ago, I think, and prior to that, Washington State had a really strong independent physician community, maybe stronger than a lot of places. There's been a lot of hospital acquisition or hospital employment in the last 10 years. How would you say the physician activation in terms of advocacy, where is that in the spectrum, recognizing you've been at WASMA 3 or 4 years now and not 15, but how do you sort of see that? Do you feel like physician activation is really strong, or is it maybe now it's through a hospital channel or very close in partnership? How would you characterize some of that physician activation?
That's a great question. So I'm getting on 6 years with the Medical Association, and even in that relatively short period of time, we've seen a lot of evolution in where physicians are practicing, and as a byproduct of that, the issues that they're interested in. I think a lot of people going back 20 or 30 years, at least the impression that people had of the Medical Association was that, it's taxes, it's medical malpractice, and that's really all that they cared about. The breadth of what physicians are interested in 2019 it's sometimes, to put it honestly, is pretty staggering. I do think, to your point, there have been a lot of pressures, and Bill, you mentioned this too, the cumulative effect of all of the laws and regulatory requirements that have been imposed, especially in recent years with since the ACA has kind of come online, has exacerbated the trend towards consolidation, towards physicians working in health systems. And I'll say, our kind of fear from the standpoint of folks who want to be independent is the net effect of a lot of things that passed during the 2019 legislative session is going to put further pressure on physician practices to consolidate, whether it's the public option bill, whether it's the B&O tax surcharge that was imposed only on independent physician groups. There's already a lot of existing pressures that are going to be exacerbated by those types of things. But on the balance, I feel like we've got, WSMA membership is higher than it's ever been. And we've got physicians who are very in tune, very engaged with whether it's things that are happening in the legislature, things that are happening at the federal level through the regulatory channels. I think there is an acknowledgement of the level of import that all of these are going to have on what they ultimately want to be doing with their time, which is helping patients practice medicine, all that good stuff.
Yeah, Caitlin, if we think about this public option bill and the benchmarking piece in there, sort of the process helped create space for primary care reimbursement in a different way than had originally been foreseen. But is there a lesson there that maybe because of consolidation in the provider space or other pressures, that maybe it takes a regulatory benchmarking tool, not just for Medicaid, but for other plans, something like Maryland or something like what was here a generation or two ago, but some sort of tool to help the market price or drive reimbursement down. Is that a takeaway in your view from these recent policy conversations?
I mean, I think Amerigroup, we were sort of in partnership with WSMA being against rate setting because it doesn't allow for as much flexibility as we may want to be able to provide providers, especially those in rural areas who may need additional support, or even in urban areas where you may not be able to recruit as much as you want because there's just not enough people, and it's still expensive to live in Seattle. It's something we still hear about consistently. So for those physicians or other specialty types that have a massive amount of debt, it's still really hard to live in high-cost urban areas. So rate setting always posed a bit of a conundrum for us because at the same time we see rate setting all of the time in Medicaid. So it's a little bit different. I think having a floor is helpful so that there is a basis at which you don't go under, which is what we have in Medicaid. But not if you have a ceiling, it just doesn't allow for things like a quality and value-based contract to even be as conceptualized because you're still modeling it off of service by service basis. You're not necessarily creating a capitated structure where there's more flexibility for providers to do what they need to do to potentially stay independent and not consolidate.
So Bill, let me ask kind of this, since it's just us at dinner and the bottle of wine, I was trained a little bit as an economist. I got a graduate degree in that. And so when I think about the employer market, first I think, why aren't they demanding more value for their dollar? And invariably I'm led to what I think an economist would say is they're not demanding more because they're getting enough. That it's not too expensive for employers because they're happy with it. If they were, now sure, no one wants to pay X when you can pay Y, but for the most part, the commercial system is delivering enough value that the employer community is not up in arms. I think that's contrary to mainstream thinking. What do you think? Is that
I
close?
And I'm interested as to how much wine is in the bottle and how much is in you and me at this point in the conversation.
Yeah.
But I think that there is some truth to that. And actually, to me, as a person who is in charge of sales for Premera, I'm a little frustrated by it. Because we try to, and my friend Stacy West is out in the audience who does a lot of provider contracting, we try to come up with innovative ways to go after cost and quality to some degree, but certainly cost for our employer groups. And when we bring those innovative things into the market, if we're going to save somebody 4 or 5 or 7%, they actually won't even really look at it. Now, when 7% of probably the second biggest line item on your company's balance sheet doesn't motivate you for change, then what's kind of going on here. So I wish we could drive more change. I do think that we hear from the employers that they're upset with the costs, and they're upset with some of the other things around value, and yet I'm not sure their behavior really reinforces that. Mm-hmm. We've seen healthcare costs double 2 or 3 times in the last 20 years, right? Mm-hmm. So I've been wrong before when I said, gee, this is not sustainable. And when we put together packages of things and take them out into the market, they don't get endorsed. Now, there's some of that I personally believe is driven particularly on the west side of the state. You think about the Seattle corridor and its success recently economically. They're fighting for talent. We built a narrower network product a few years ago when I was rolling it out to one of our advisory councils, and one of the people said, "This is a great product. I love the design of it." And of course, being the sales guy, I said, "Would you like to talk more about it?" He says, "Well, I'm not going to buy it. I'm in between Amazon and Microsoft and Google over there, and I'm competing, so no, I'm not going to buy this product."
Yeah, interesting. So Pam, there was this old kind of comment, and it was at least around during the ACA, and it's probably been around longer than that, which is essentially, if it ain't broke, don't fix it. Most of healthcare works for most of the people most of the time. And that really what we need to do is focus on, high cost or the places where it breaks down the most. And so if we build on this idea that maybe the group market is okay, and if Medicaid is, actually much more innovative now than a decade ago, it nevertheless still leaves the individual market where people, particularly non-subsidized folks, have tremendous out-of-pocket costs. Mm-hmm. Does that argue that maybe we should be spending a lot of our policy time thinking about the individual market and maybe less policy time on group or Medicaid because those are well enough, relatively speaking?
That's an interesting question. I do think that the individual market is the canary in the coal mine. It's kind of where problems show up first.
Yeah.
And a lot of the issues in the individual market is not the quality of care they're getting, or even in some cases the benefit design. It's the affordability issue, which is that people are paying the full cost of their insurance in many cases, and it is really unaffordable. And there's such a small percentage of the market that they don't have bargaining power. Even Premera, which has a lot of clout in the market, the segment that is in the individual market is pretty small, and that makes it hard to drive, better arrangements. A lot of our healthcare system is based on these bargaining arrangements for large groups. So I think that in that sense, the individual market kind of stands alone. Mm-hmm. On the other hand, I think that kind of to Bill's point, we maybe have come to the end of how these things are working. I think that there starts to be this kind of arbitrage among all the different payers to try to make ends meet for your group practice or your hospital or whatever entity you're running in healthcare. And you have to kind of figure out among all these different groups, where you're going to get your revenue from. There's a lot of energy that goes into that. Yeah. And then there's a lot of energy that goes into coding and upcoding and downcoding and how these all payment things. And it's, it starts to get, you kind of want to stand back and say, could we do some of this better? But it's really hard to make those changes. And we have a lot of, there is, what Sean's saying about practices, there is a lot of frustration in practices about administrative work, data systems that don't work, how many screens you have to log into and out of to take care of your patients. Those system issues, they're problematic and they need to be addressed.
Are you, you've seen some of these wars come and go as we were talking, or you were talking on the side and I was listening, talking about the early healthy options conversation in the early 90s, of course the ACA more recently. Are you surprised that the current Democratic nomination process does not include really very much conversation about, quote, building on the ACA? It's really focused on this other kind of Medicare for all, single payer, some other thing. And even though you have folks like Nancy Pelosi committed to building on the ACA, that is not a tagline you hear amongst Democratic candidates for president. Does that surprise you, or what do you think?
Well, it doesn't surprise me because I think that the candidates that are on stage right now are trying to engage a certain segment of the electorate so that they can get the nomination and they can continue to raise money and continue to stay in the game. And they're going to do that with a big, bold idea. I don't really know how you get to those ideas given the congressional system that we have. So I'm not surprised by the dialogue. I think that if there's not a lot of movement in Washington, D.C., but when I'm there, the discussion is much more about making the ACA work, and then let's think about what we could do next incrementally. I think that's where most pragmatic people are, but most pragmatic people aren't running for president right now.
Yeah. So Caitlin, where is the role of the state in this? I mean, in terms of policy and trying to support some of the market activity that we are talking about, do you think it's a time to kind of sit on our hands and let the federal chips fall wherever they're going to fall and then go from there? Or is this a time really where Washington State needs to be a leader and move forward, like on the public option, maybe differently than the public option, but chart our own path? What would you say?
I think it has to be a combination of both, which I know is kind of a cop-out, but part of that is because it's hard to get Medicare untangled from the federal system. And Medicare increasingly is covering so many people. And in particular in our state, we're having a lot of people move to our state to take advantage of all of the different systems that we have. And that means that we're going to have more interaction with Medicare just generally in our state. But I think that we all seem to have a collective goal, and I heard this even in the work sessions in July in Olympia, of getting to universal coverage. How do we get to better coverage for people, which I think was really the ultimate goal of the public option, to the point of some people are paying $900 a month for a plan, which, to be honest, that's what my mother pays, and she's one of the healthiest people that I know at 63, but she's 63, and she's not on Medicare yet. So she pays $900 a month, is retired, and uses her retirement income to pay that. So I think she's made that choice because she worked in healthcare her whole career, so she knows that it's important. But not everybody can make that choice. And some of the people, we've seen a lot of, as great as the increase in minimum wage was in King County and Seattle, to $15, what we saw was a lot of people got kicked off of Medicaid because they suddenly made too much money, which is just sad. And Medicaid is free healthcare. So those people now have to deal with an entirely different system. Some of them still don't think it's worth, even though in a reduced premium that they would get, because their premium would be really reduced, it's still not worth it. Mm-hmm. So aiming towards universal coverage, I think, is something that we can all try to figure out solutions for. But we always do have these sort of like small arguments of like how to piece the system together. And that kind of always holds us back. So it's trying to sit down and really think through what we want the system to look like, and then aiming there. I think that a vision for that would be great.
Yeah.
If I could tag on just a bit too, that also letting things, a lot of big health policy initiatives passed last year, and letting things breathe a little bit. I think we all have a tendency to come into session and it's like a blank slate to work from. I think it's important, and in part, to Pam's point, people run for office talking about wanting to build a bridge, not wanting to fix a bridge, right? And so like we're constantly being inundated with the next new big idea. A lot of big ideas passed last year, and it's important to kind of let those be implemented, let them kind of settle into the market, see where that leaves us before we immediately jump on to whatever the next big thing is that we should be working on, at least at the state level. We can't, some of us don't work on the Fed stuff, we can't tell them what to do. But at least at the state level, I think that's important too.
So we're starting to get near the end. Sean, let me ask you first, this idea of, that I asked earlier of other folks, what counsel would you give people in the audience or people watching this about this, what at least I have characterized as this tension between a political force building and sort of exhaustion on the healthcare side, and how it seems like that gap is getting wider. Do you see it similarly, and how do we fix that before things tear apart?
Well, I think it's difficult because there does continue to be, first of all, and I just said we need to let things be, implemented and all of that. There's real problems with the healthcare system, and it's totally understandable that especially folks who are running for president would do so on a platform of wanting to improve and or fix the system. From the physician perspective, this is an area, especially when you talk about like big healthcare reform issues, that kind of puts us in a tough spot, and in a good way. We've got a very diverse membership, and so when something on the state level like public option comes up, or at the federal level, something like Medicare for All, whatever it is, we're hearing different things from different elements of our membership, and everybody, by and large, physicians are engaged. They want to be working on this. But sometimes synthesizing that down into a consolidated position on an issue is difficult to do.
Yeah, if it were easy, it would be done already. Caitlin, similar question within the context of the Yeats poem that I cited earlier today about the center cannot hold and that things fall apart. What is your advice and counsel to us collectively to try to hold it all together during this time where we just feels like to me that we really want to pull things apart?
Yeah, I think, I think there are certain pieces of the system that still need to be sort of held together, but there are pieces of the system that kind of do need to be broken apart, and it might be worthwhile to spend some of our energy on some of the most broken parts of our system, which, at least from what I'm experiencing lately in a lot of my daily work, is around behavioral health. Our system is broken here, and it's not due to anybody's problems or incapabilities of serving that population. We don't have enough providers. We don't have enough support for those providers. Rates are terrible. The whole rate setting system for behavioral health needs to be redone. I mean, there's so much that we could focus on, and we just cut a slice of it in this last session. That maybe, taking Sean's advice and letting the individual markets see how this goes. We have to see how public option plays out before we can do anything to restructure it again, and putting energy around behavioral health, not just for Medicaid, but it affects everybody. It affects the commercial population, mental health parity, even in our standard plan conversations, that has a lot of impact that's come up there, and how you design a standard plan that can account for mental health parity when the cost of a behavioral health hospital visit is astronomical. Yeah. And it should be. That's a very specialized population. But we haven't had a real focused understanding of how to reinvent that system in a Washington way that I think it would be due for us to carry forward.
So Pam, similar question, but specific to policymakers. What counsel would you give the policymaking community about how to hold it together while we go through this trying period?
Well, I agree with other speakers who said that we actually did a lot of good work in the last session, and I think it really behooves us to kind of follow that through, and that does include behavioral health. There were still strides that were made. I know there's work going on the opioid crisis that is really important, that we make some strides there. We have an all-payer claim database in our state, which has already been tremendously valuable to the exchange in understanding how we're spending money. So we need to kind of get that up and running and working. So there's these big things that will be very helpful. And I think that taking some time to really follow those through and bring those to fruition, I think is probably the most important work we can do. I think that the innovation is going to happen at the state level for the next several years. And I think our state is uniquely poised to continue to innovate. We are good at bringing people together. And we have it out and arrive at solutions. We find compromises, and we continue to innovate. And I think that ideas like Medicare for All are really important. I just don't know how we get there from here, given the situation in Washington, D.C. So I think we have to look to ourselves and start working on these things. But to the earlier comments, we need to pace ourselves as well.
Yeah, interesting. Bill, last word. What counsel would you give market actors, the private sector, the folks who are doing this work either on the delivery or financing side, in order to help bridge this anxiety in the public policy space with the exhaustion in the market side?
It's a really good question, DJ, because I think like minds, similarly disposed minds might come to different conclusions. I'm not sure that I would have given the last legislative session an A+. There were some things in there that are pretty challenging, and they're big, and a lot of them. And if I look at the private market, not all of them I think were great for the private market. They may have been well-intentioned. We'll see how they play out. So meanwhile, I do think that the private market, to some degree, because one of the things we haven't fixed is the cost shift that is inherent between the private sector and the public sector, and that lands on WSMA and WSHA and all sorts of other people. It certainly lands in the private market purchaser too. And behavioral health is an issue. These are all things, when we go out, we have these things that we do with our larger accounts called knowledge management meetings, and it's a nice 4-hour session where we sit down and look at all of the information about a particular group. And behavioral health, 5 years ago would not have been a number 1, number 2, number 3. It's in the top 5 of everybody's spend. And not just the money, but we all know what the impacts of that particular disease state are on not just productivity, but just families and individuals' lives. But certainly even the cost piece is just astronomical.
Can I clarify what you just said there?
Yeah.
With your large accounts, behavioral health is in the top 5 of claims?
Pretty much everybody's spend. And you'll see that on the drug side, and you'll see it in terms of frequency of diagnosis.
Wow. Co-occurring also, not just pure BH, but a part of a bundle of diagnoses.
Right.
Yeah, interesting. Why do you think that is? Is that because we are getting crazier? Not to be flip,
I think it just, I don't know why the private market would be any different than the society at large. And I think we've seen an explosion of both the issues themselves, some of them substance related. We've seen an increase there, and that's driving some of this.
Yeah.
But I think we're also seeing greater awareness. And so the needs are being exposed more than they used to be.
Yeah, interesting. Well, I'm sure politics has something to do with it. I would be sad to say that. Let's give them a round of applause. Thank you guys very much.